I believe it's 6 o'clock and we can begin our meeting. I'd like to call the January 11th meeting of the Board of Directors of Washington Hospital to order and invite all those that can to stand with me and join me in the Pledge of Allegiance. I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible,
with liberty and justice for all.
for all. Thank you very much. Dee, if you could call the roll for us.
Director Stewart,
Present.
Director Wallace,
Present.
Director Nicholson,
Present.
Director Eaton, Director Yee.
Present.
Thank you, Dee. And can you tell us who's in the room with you, Dee?
In the room, we have Kimberly Hartz, Chris Henry, Larry Labossiere, Tina Nunez, Paul Kozachenko, Sri Badu, and me, Dee Antonio.
Good. Thank you very much. All right, welcome to the January 11th, 2023 regular meeting of the Washington Township Healthcare District Board of Directors meeting. To continue to protect the health and safety of the members of the board, district staff, and members of the public from the dangers posed by the SARS-CoV-2 virus, the Brown Act allows for local agencies to continue to hold meetings remotely as opposed to being required to meet in person. Section 54953E3 of the Government Code requires that the board make certain findings every 30 days to continue meeting remotely. One such finding is that the state or local officials continue to impose or recommend measures to promote social distancing. The Alameda County Health Officer continues to recommend social distancing and the wearing of masks indoor. I refer the public to the Alameda County Healthcare Services Public Health Department COVID-19 website at www.covid/19acgov.org. I ask for a motion from the board making the finding required by section 54953E3BII of the Government Code that state and local officials continue to impose or recommend measures to promote social distancing.
Mr. President, I make the motion that the board make the finding required by section 54953E3B2 of the Government Code that, quote, state or local officials continue to impose or recommend measures to promote social distancing.
Thank you, Jeannie. We need a second.
Second.
Good. Dee, if you could call the roll on that.
Director Stewart,
Aye.
Director Wallace,
Aye.
Director Nicholson,
Aye.
Director Eaton, Director Yee.
Aye.
Thank you. That motion passes. Public notice for this meeting, including dial-in information, has been posted appropriately on our website. Tonight's meeting will be conducted by Zoom. I ask that you please mute your system until such time as you need to speak. We are recording tonight's regular session of the board meeting. It will be posted on our website for future viewings. Members of the public, under the area of communications, members of the public are invited to speak during oral communications. When prompted, please state your name for the record, then proceed with your statement, not to exceed 3 minutes on issues or concerns not on the agenda and within the subject matter of jurisdiction of the board. Are there any members of the public who would like to speak at this meeting? Hearing none, we'll move on to our consent calendar. The consent calendar consists of those agenda items that the board will approve with one motion unless either a member of the board or a member of the public requests to remove an agenda item from the consent calendar. If any items are removed from the consent calendar, the board will take action on the removed agenda item later in the meeting under the action item headings of the agenda. Does anyone on the board want to remove an agenda item from the consent calendar? There being none, Does any member of the public want to remove an agenda item from the consent calendar? Hearing none. May I have a motion on the consent calendar items A through C?
Yes, Mr. President, I move that the Board of Directors approve the consent calendar items A through C.
Second.
And we have a second. Dee, if you would take the roll for us, please.
Director Stewart,
Aye.
Director Wallace,
Aye.
Director Nicholson,
Aye.
Director Epen, Director Yi.
Aye.
Thank you, Dee. That motion passes. We can now move on to our presentation part of the agenda. Kimberly, if you could introduce that for us.
Yes, thank you, Dr. Stewart. It is my pleasure to introduce Dr. Norwar Mustafa. He's an interventional cardiologist with special interest in prevention, diagnosis, and treatment of heart attacks and heart valve problems. He joined Washington Township Medical Foundation from Ohio Health in Marion, Ohio. Dr. Mustafa has a passion for teaching and is well-experienced clinical educator with previous academic appointments at Ohio University, University of Kentucky School of Medicine, and the University of Pikeville. As a fellow, Dr. Mustafa won the prestigious American Heart Association Young Investigator Award and has recently earned his Global Clinical Research Scholar Certificate from Harvard to build on his early career research contributions and refine his skills. In addition to this prestigious award, his board certifications include internal medicine, cardiovascular disease, interventional cardiology, echocardiography, nuclear cardiology, and coronary compound tomography angiography. Mustafa's interest toward clinical science began in his childhood life when he watched his late father struggle with a rare medical condition. With his well-rounded exposure from Jordan to many regions in the United States, Dr. Mustafa has a global perspective towards patient care. In addition to English, he is fluent in Arabic. Dr. Mustafa is married to a family physician and has 4 children. His hobbies include hiking, reading, and playing with all of his little ones. So it is my pleasure to introduce Dr. Mustafa, and he is going to be talking about coronary artery disease.
Thank you, Kimberly, for the nice introduction. First, I would like to thank the board for this invitation to speak in this meeting. I'm going to try to share my screen and see if that works out. Can you see the screen?
Yes.
Yes.
All right. So the presentation today is going to be about coronary artery disease. My name is Nouar Mustafa. Can you hear me?
Yes.
All right. It's keep giving me a message that it quit, but it seems still working. I'm a cardiologist at Washington Township Medical Foundation, joined this summer. So,
Doctor, do you mind if we share it, share our screen, and you can let me know if you want me to go to the next slide, since your computer is.
Can you see my? Either way, you wanna do it from your end or my end? I'm fine.
Yeah,
way.
let me do it for you.
Okay, let me just stop sharing then.
There we go.
So you're in control now.
Yeah.
All right, let's go to the next slide. And let's go to the next one, please. All right, so when we talk about the heart, we can't talk about it without talking about the cardiovascular system. So the heart and the blood vessels and the lungs together kind of work in unison. So the heart pumps blood to the lung to get oxygenated. It comes back to the heart. It gets pumped to the rest of the body to supply blood and oxygen. The heart muscle itself cannot use the blood from inside of it. So it has its own blood vessels as well to supply it with oxygen and other nutrients. Next slide, please. When we talk about coronary artery disease, we're talking about atherosclerosis or hardening of the arteries. And that's true for all the arteries in the body. So normal arteries are thin and flexible with age and risk factors. Cholesterol deposits start in the wall of the artery, attract inflammatory cells and calcium and other stuff, and result in hardening of the artery and the stiffness of the artery itself. Next, please. So there's many risk factors for atherosclerosis. The common ones or the well-known ones, including diabetes, smoking, hypertension, hyperlipidemia, obesity. But we're recognizing other factors, behavior, psychological factors, in fact, educational factor, employment status, all these things that affect the human beings also can increase the risk of atherosclerosis and CAD. Can we know next, please? So as we said, the atherosclerosis is a disease of the blood vessels, and it can happen in any arteries supplying any organ of the body. Next, please. So if it happened in the brain, that's when someone have a stroke. Next. If it happened in the artery supplying the heart, that's when a heart attack happened. Next, please. And if it happened on the arteries supplying the legs, for example, or the extremities, that's where PAD or peripheral arterial disease happens. So it is the same disease process, depending where the severe abnormality happened, and the symptoms may differ. So that's why if someone have a history of a stroke or PAD, they're a high risk of CAD or heart attacks and other vice versa. Next, please. So coronary artery disease is the narrowing of the coronary artery, the arteries that supply oxygen to the heart. When there is narrowing of the artery, depending on the severity of the narrowing, it can result in chest, heart attack, and heart rhythm problem. It's a common problem. It kills close to 400,000 people a year in the United States. Next, please. Chest pain is the most common symptom that people with coronary artery disease or atherosclerosis of the heart have. And the typical chest pain from heart is called angina. That's usually tightness, squeezing, or burning in the middle of the chest, usually worse with exertion. It will go to the neck, the arms, or the shoulder. So that's the typical one. But sometimes it doesn't follow the textbook, and it could present with other symptoms like shortness of breath, or it could feel like indigestion, or people may have only nausea, vomiting, or fatigue, or tiredness. Although it's important to recognize the typical symptoms, but to keep in mind that it also can present in a very subtle, non-specific way. And that's usually true more commonly in women and with older age, that the symptoms might not be very typical. Next, please. So when the artery is completely blocked, that's when a heart attack happens. That's one area of the heart will not be getting enough blood. And that's when the toxins start build up, and the pain and the damage to the muscle still happen. And it's also common, 800,000 heart attacks in the US each year. And one thing to remember about heart attack, that's time is muscle. The longer the blockage persists, the more damage to the heart muscle will be. And the symptoms, it's similar what we talked about in the previous slide about chest pain. Because time is muscle, with the earliest sign of any of these symptoms, very important to call 911, get evaluated so that it can be corrected in a timely manner. Next, please. So hopefully we don't want to be dealing with treating heart attacks. The goal is to try to prevent heart attacks. Keep in mind that 1 in 2 adults in the USA during their lifetime will develop heart disease. So it's become very important to start preventing the problem. And to prevent heart attack, the work should start decades before that we expect it to happen. So this is something that we need to start early in life to prevent it from happening later in life. Next, please. And when it comes to preventing heart disease, there is no magic pill. So there is one lifestyle, and adopting a healthy lifestyle and avoiding bad habits is very important. Avoiding smoking, adopting healthy eating plan, exercising regularly, managing stress. We're realizing that stress is as bad a risk factor as any of the other ones. So managing stress in life is very important. Knowing the numbers, knowing what's our blood pressure so that it can be treated, knowing what's our sugar numbers so that it can be treated if needed, knowing our cholesterol numbers, and keeping and maintaining a healthy body weight also is important. Next, please. When it comes to heart healthy nutrition, that kind of seemed to be easy said than done, but the number one advice is the portion control. The amount of food we eat, and then become the type of food we eat. Basically having more fruit and fresh fruit, vegetables and nuts, more lean meat or white meat, avoiding high fat food, high sugar food, high salt food. So this is kind of the things to avoid: the salt, the sugar, and the fat. And even when we can't eliminate them completely from the diet, we go with choices with healthier fats, for example. There is multiple diets you could hear of, and all of them kind of have a combination of one of these or another. The idea is to have a good portion and have a balanced diet. Next, please. Salt is also very important. Cutting down on the salt is very important. There is no harm of eliminating the salt completely. I know that sometimes food doesn't taste as good without it, but getting in the habit of reading the labels, and the best way is to read how much is a serving has, rather than just because with marketing, a lot of things that say reduced sodium or low sodium does not mean the same thing. Try to get as low sodium in the diet as possible. Next, please. Now, with physical activity and stress reduction, also very important. And with this regard, like many things in life, having something consistent, even if it's not very intensive, is better than doing something that is intensive and we can't keep up with it. Moderate exercise can be as simple as dancing, gardening, brisk walking. That's also very helpful. For stress reduction, we're talking about like breathing exercises, meditation, whatever works for you to decrease the stress level, you should be doing it. With moderate exercise, the goal is to have at least 30 minutes a day, every day of the week, or if you want to do 3 times a week, for example, at least 1 hour 3 times a week. So up to 150 minutes a week is kind of what's recommended at least. Next, please. So next. So today, when someone concerned about having it, the first element to look for to diagnose the problem is to with the physician meet with you, take a detailed history and exam. Next, please. Next, and then next step would be doing an EKG or an electrocardiogram. Next, you might order an ultrasound of the heart or echocardiogram. Next. Then if there is suspicion of having a blockage or coronary artery disease severe enough to cause symptoms, a lot of times the doctor will order a stress test. In simple terms, the stress test, what we're trying to do is we're trying to increase the workload on the heart to see if it can achieve, if there is a blockage, it will show up, whether it's in symptoms, whether it's in the EKG changes, whether it's on the echocardiogram, or in a nuclear study. So we try to increase the workload of the heart. If there is no blockage, it shouldn't be a problem. If someone has a blockage, it will show up one way or another. That's one way of looking at things, doing a stress test. Next. The other way of doing this is looking at the structure of the heart, looking at the arteries themselves to see whether there is a blockage or not. The stress test look if there is enough blood flow. We don't see the actual blockages. There's other ways we could do. We would look at the arteries themselves to see whether there is any blockages. One way of doing that is during a CT scan of the arteries, specialized CT scan of the heart and the coronary arteries, and it could see whether someone has a blockage or not. Next, please. Of course, the and that's non-invasively. If sometimes if all the non-invasive tests are not conclusive or show possible problem, they might need to do a coronary angiogram, which is an invasive procedure where we put catheters, wires inside the blood vessels, inject dye, and take X-rays to see whether someone has a blockages or not. Next, please. So if someone is diagnosed with coronary artery disease, the first line of treatment, if it is not already applied, is lifestyle changes. So the same lifestyle changes we talked about earlier, that would need to be implemented. The next step would be medications. And there's different kinds of medications that can be used. One, to control the risk factors, and also there's certain medication we use to prevent or treat chest pain or to prevent heart attacks. Of course, all the risk factors need to be controlled, including blood pressure, diabetes, cholesterol, all these things. Next, please. Next. Now, that's kind of medication, the lifestyle and medication is the mainstay for people who are stable. But if these medication fail or they present with acute heart attack, then at this time they need to act quickly and the patient may need a procedure. The first kind of procedure we can be done is percutaneous coronary intervention, or stents basically. So we do a coronary angiogram and then we use wires and balloons to open up the blocked area, and we leave behind a stent or a mesh-like structure to keep the artery open. So that's one way of doing it. Next. Sometimes that's not enough or not safe to do, especially with people with multiple blockages that cannot be treated well with stents. They might need open heart surgery to do bypass, like open heart or bypass surgery, which basically use blood vessels from other areas of the body to bypass or the blocked area. You could think of it as a detour around the blocked area. Next, please. So that's basically when it comes to the coronary artery disease. Final word about aspirin. The last couple of years, there's a lot of talk about aspirin. They will use it. I want to make sure that if someone had a heart attack, a bypass surgery, or a stent before, they need to keep taking their aspirin. They should not stop their aspirin. The time when there is a question whether someone needs an aspirin or not is when we for prevention. Someone who never had a heart attack, never had a stroke or a stent before, then there is a discussion, to have a candid discussion with your physician whether aspirin is needed or not, because for most people, aspirin is not recommended as a prevention. Next. That's all I have. Thank you for listening, and we open if you have any. Can you go to the next slide, please? Yeah.
Thank you very much, Dr. Mustafa. That's very helpful to get a general outline of all those possibilities and things. That's been a very hot topic for me in my life because my mother died of a heart attack at early age of 50. And so it's motivated me to live the life that you've prescribed.
Well, that's the best way to do it.
Yeah. Are there any other questions from the board?
No, thank you very much. It's timely. Beginning of the year, everybody wants a fresh start and promises to do better in this area. So thank you for the encouragement.
Time to look at the diet again. That's always that's always a challenge.
Yep. Thank you, doctor. Thank you. Hey, I know Bernie doesn't do this, but right now I'm in my 11th day of dry January.
Good for you.
Dry January. That's a new term for me. Way to go. Again, thank you very much, Dr. Mustafa.
You're welcome. Thank you again for inviting me.
Yeah, very nice to see you and very nice to hear your report. It's great. Thank you. Thank you. Well, our next item on the agenda is our reports. We'll We'll now ask Dr. Where'd he go? I thought I saw him just a minute ago.
He's there. Yes.
Dr. Hyder, if you could give your report.
Yeah. Good evening to all. Happy New Year. Thank you so much. First of all, I want to tell that our flu vaccine are doing very well. We have done 90%, which is very, very good. And the TB stands at 86%. And yesterday was a general medical staff meeting, and it was well attended. And we announced that those who are declining the vaccine or TB test, they should submit the report to the medical staff office, the doctor's letter or whatever it is. The other thing is with the thanks to the board as well as Ms. Hart's, that there will be a medical staff lunch at the Chinese New Year on the January 24th in the cafeteria at the basement, starting at 11:30 to 1:30. And we are grateful to the administration and the board. The other thing is to comply with the new California state law. Yesterday I stated SB 864. The lab has added fentanyl level to the urine drug screen. So far, we never used to do, or they never used to do, when you do the urine drug screening. So it will come separately, but the result will be reported for the fentanyl level when the urine screening is done. And the numbers of medical staff category in January up to January 2023 is we have active 336 members, administrative is 1, advanced practice is 38, ambulatory is 96, consulting is 7, courtesy is 24, provisional is 90, leave of absence is 5, and temporary privilege is 1, which stands at 598 total staff. And we have, the administration and infectious disease, and they have asked all the staff, those who come in contact with the patient, to have N95 for this month, as the COVID and the subvariant is increasing, even though it's not severe. That's my report.
Thank you very much, Dr. Hyder. Are there any questions for Dr. Hyder? Again, thank you very much, Dr. Hyder. It's always nice to be brought up to date on those things.
Thank you so much.
We'll now move on to our Service League report. Anxious to hear from you, Debbie.
Oh, thank you. Well, good evening, members of the district board and the staff, and Happy New Year from the volunteers. For the month of December, we had 166 Service League volunteers contribute 1,929 hours to the hospital. December was a big month for orientations. We took advantage of our college students being home for the holidays, and we hosted 2 orientations, one on the 10th and one on the 28th. And attending the orientations were 4 adults, 14 college, and 70 high school. We're excited to welcome such a large group of volunteers, and who will be staffing the hospital lobby, gift shop, and the birthing center. And you'll be seeing a lot of new faces in the hospital. So if you can say hi to the new volunteers, it would really be nice for them. They would enjoy that. On December 14th, the Service League also hosted an event, a social event, and over 30 volunteers came to it, and they decorated cookies. One volunteer brought her granddaughter, and so that was a real joy for all of them, was having the little one there. It was nice seeing all these volunteers being able to relax and have a good time. And that's the Service League's report for this month. Do you have any questions?
Thank you very much, Debbie. It's always nice to hear about the volunteers. There were
Thank you.
70 high schoolers.
Yes, yes.
Wow. Is that from a variety of the high schools, or is that just some specific ones?
I think it's mostly just Fremont right now. I think there's a couple from Newark, but mostly just Fremont. And because of us being, shut down for COVID for so long, all these new volunteers, the high schoolers are anxious and their counselors are really anxious to get them in volunteering. So it's really nice because they're very eager.
Wonderful experience for a high schooler, I think, to spend some time at the hospital.
Oh, yeah. I remember as a kid, because I grew up in Fremont, and I remember Washington Hospital and the little pink ladies. And, it was like, where are you going? I'm not going anywhere. So, I mean, yeah, I have a long love for Washington Hospital. So
Good. Thank you very much, Debbie.
thank you.
Great work over there.
Thank you.
We're now ready for our quality report. Kimberly, could you introduce that for us?
Yes, it's my pleasure to introduce Dr. Diane Martin. I know she's familiar to the board of directors. She has been a member of the Washington Hospital medical staff since 1984. She has served in many leadership roles at Washington, including chair of the Department of Medicine and chair of the Clinical Evaluation Committee, which includes pharmacy and therapeutics and infection control. She has been our physician champion for our 5 Million Lives campaign, and also has played such an important role in infection prevention throughout the healthcare system. Dr. Martin attended school in Charleston, South Carolina, after which she completed her internship and residency at the University of Kentucky School of Medicine. She received a fellowship in infectious diseases at the UC Davis School of Medicine. She serves on the board of directors of Life Elder Care and is a member of Washington Township Medical Foundation. Do we, is she on? Let me see. Mary, do you?
Can you can hear me?
Yes, we can hear you, Dr.
Okay,
Martin.
okay, all right.
Great.
I don't seem to be able to fix the video, but whatever.
Okay.
So it's my pleasure to update you on the infection prevention program. And we've done a lot of really innovative stuff this year. So I'm really excited to present that, and it's an honor to present it. But I talk from my perspective, but we also have a huge team behind us that's multidisciplinary, and it's also sort of semi-chaired along with me with Gulnaz, and as well as our strong support from Mary Boron, who was an infection preventionist for quite a long time before she now has her current role for quality. So next slide, please. So just as a little way of background, there are a number of infections each year that affect our patients. It's almost 1.7 to probably closer to 2 million infections per year, and about 99,000 or almost 100,000 deaths each year. And that's something we really want to focus on to reduce those numbers. And we estimate in California alone, there's 250,000 patients admitted that will get a healthcare associated infection during their hospital stay. This contributes to the suffering that a patient already has with being ill, and also increased costs to both patients as well as our healthcare system and our individual healthcare system in Fremont and the Tri-City area. Healthcare associated infections alone are among the top 10 leading causes of death in the United States. The thing I'd like to focus on with this talk is to show you that these are preventable. We can change this. And it's a team effort, and we need both, support from our infection control, from patients and their families, and we have huge support from administration. They have backed almost everything we have asked for, including the board when they gave us that huge MALDI-TOF that helped us identify bacteria so fast. And there's a lot of A lot of hospitals don't even have that opportunity. So there is a lot of things that we can do. We do close monitoring, we do education, not only of the doctors, the nursing staff, we also do it to the whole hospital staff as well as to patients. We try to build up awareness and to make sure that we are consistently using evidence-based practices that come from both CDC and the Centers for Medicare and Medicaid to make sure that we're ensuring that our patients, as well as our staff and our physicians, are all safe. At Washington Hospital, infection prevention is a huge hospital-wide discipline. It's not just restricted to patients who get sick. It's not just restricted to pharmacy. It's not just restricted to infectious disease physicians, but it's hospital-wide. And it's a huge team effort that you can see as I'm going through. We have done great strides to try to prevent, identify, and control the spread of infections. So one of the things that we're working on, next slide, is Infection Prevention Committee. So this has been in the background for a number of years. We started in 2006, what we called our 5 Million Lives campaign, where we were focusing mostly on staff and also multi-resistant staff. So we've been looking at hospital-acquired infections and reporting them to the NSHN, which is National Healthcare Safety Network. So I'll be saying NHSN rather than all those words, which is actually part of CDC. So we started reporting in 2009 and we report annually. We have a very strong focus on our program. So we are 24/7 working with prevention and to eliminate infections. We reduce surveillance of hospital environment. I'll get to that in a little more detail. We do real-time reporting and analysis. So this goes through to the nurses' huddles, and I'll talk about that a little bit more, that are working on the individual units. Also to things like the lab, dietary, which is working with the food safety, to the physicians, we're reporting that. We also have surveillance software, which is helping us sort of detect patterns amongst the infections, which again was the Molotov, which the board strongly supported and helped us acquire. We also do hospital-acquired infection reports. So report not only to the board like this, but last night I presented to the general medical staff, so to the physicians across the board. We also report to individual departments, family medicine, general medicine, surgery. We also report to different committees, pharmacy committee, and also clinical evaluation committee. So at the coordination of this team is me as a physician consultant, but also Infection Prevention Program Manager Gulnaz, Mary, who's our Chief Quality Officer. We also have other infection preventionists who work for us part-time, Laura Tang and Lisa Hansford, and we could not do anything without them. They are our backbone. We also have very strong support from nursing. I have to admit, when we have made rounds and try to do education, talk to the nurses to see how they perceive what we're doing, they've given us a very strong response, and they're very motivated to make sure that we provide quality care and safe care for all of our patients. We also work with quality and resource management, compliance and patient safety, the physicians as a whole, central processing, where they're doing sterilization of all of our equipment, environmental services, who's responsible for cleaning our hospital top to bottom, and to make sure that they're doing this in proper fashion. Again, like I mentioned, nutritional services, we work with them, laboratories, I mentioned, pharmacy. The OR is very careful with how they want to restrict prevention of infections, because they're working on patients trying to get them healthy and home and not have complications. Cath lab the same, and also medical imaging. So this team, as you can see, it is very diverse. It's a very large team, but it's been very, very supported from every discipline. So the key program components right now are our multidisciplinary animal quality stewardship team. We also have employee health. They give us a great strong support, especially I'll touch base a little bit later on with trying to work with some of our staff who have had COVID, exposure to COVID. So they've been a very strong part of our infection control program. We also look at transmission-based precautions. How are we doing with hand hygiene? We also look at risk assessment for construction, and I'll show you a little bit about that in another slide. We also look at outbreak management and public reporting, which mostly goes through Alameda County. And again, we started recently a COVID response planning. So these are areas that I'll get to a little more detail going forward. We also do active surveillance of infections with what we try to call a root cause analysis. In other words, look at something fairly serious. How could we have done anything to prevent this? Also going forward, do we need to change how we approach things? Do we need to change our protocols? Do we need to change any of the, I'll get this a little bit later on, some of the products that we use for cleaning. So mostly this is looking at surgical site infections as well as hospital acquired infections. The staff is basically all of us. So we do annual employee education, orientation. We do lessons that are learned from the root cause analysis and training. We also try to work with the patients individually. How can we help them to be safe and reduce infections? And how can we help the family? Because a patient who has an infection is going to go home and the family wants to be reassured. How do I help take care of my family member? How do I prevent this from happening in the rest of the family? So we work very careful with them. We mostly have one-on-one with the nurses, and we also have guidelines that we give them, flyers. We have isolation precautions, and I'm sure you've noticed over time, this changes quite a bit. So we have ones that are very strict that are for TB, which I'll get to in a little bit, methicillin-resistant staph, but our COVID isolations have also changed. We focus very strongly on hand hygiene. I keep telling people you can't wash your hands enough. Just that's prime factor for trying to reduce infections. We have gone back to universal masking. We had that, we sort of let it go. We're really bringing that back again, not only for our visitors and our staff as well, especially if they're in high-risk areas. And again, we update the visitation guidelines through Alameda County and the CDC to make sure that we are current with whatever the recommendations are at the time. And again, we try to explain to people this does change, but we try to stay up to date to make sure that we are current and we have evidence-based support for it. So we do evidence-based policies and procedures, our cleaning and disinfection practices, and I'll get to that again in a little bit, sterilization of devices and equipment that's used on the floors, the OR, and the cath lab. And again, we really, really emphasize hand hygiene compliance. There's sometimes when we probably are not meeting our goals, but we try to work with people one-on-one to very politely encourage them to please wash their hands. We are also tracking and managing multi-drug resistant organisms. So we look with our antimicrobial stewardship team, which is mostly infectious disease physicians, how we can educate people choosing the right antibiotic so we can prevent these organisms from spreading. We also do oversight of other departments and infection prevention practices. For example, laundry, environmental services, food and nutrition services. We also try to very, very strongly encourage employee education, orientation, and training, both when they're new hires and then on an annual basis. Next slide. So one of the other strong things that this program does is data reporting. So we report our data to the NSHN, the National Healthcare Safety Network, which is again part of CDC, and basically their healthcare associated infection surveillance is considered our gold standard. So when we benchmark ourselves and report our data against them, then we try to see, are we meeting the standard that is appropriate for a hospital of our size, our location, and our resources. So, and I'll show you, we're actually better than most of the other areas. So we have really, really worked hard to try to get ourselves at a very, very low rate for infections. We also do data reporting to the Centers for Disease Control, which again is part of the NHSN. This is voluntary, it's on an annual basis, and it's done for almost 7,000 acute care facilities and probably a total of 22,000 healthcare facilities in all. We report to the Centers for Medicare and Medicaid Services, and this gets the data nationally from the NSHN on a quarterly basis. And we're required to report measures for what we call value-based purchasing and hospital-acquired condition. So what we focused on pretty much is CLABSI, which is catheter line associated bloodstream infections, and I'll get to that again a little bit later. CAUTI, which is catheter associated urinary tract infections. SSI, which is surgical site infections. C. difficile, which is a bacteria that is carried in some people's intestines, but in the right situation can become more aggressive. MRSA, which is the methicillin resistant Staph aureus, so this is the one that's much harder to treat. And then also the vancomycin resistant enterococci, which are also very difficult to treat. So those are the ones we really want to try to focus on, reduce it if all possible, and I'll show you the data on that a little bit later. We also report to California Department of Public Health, and this is state mandated, and our data goes from the NSHN quarterly. And again, we also report to Alameda County. We communicate with Alameda County on a pretty regular basis, knowing what other areas of the county are doing so that we can sort of benchmark ourselves and sort of follow trends. So they're very easy to work with. At one point, it was a little bit challenging, but this current team is very easy to work with. And especially they've been so supportive in terms of working with the COVID. Next slide. So this talks about infection prevention regulatory updates that we've done in 2023. So we are working very strongly with CDC regarding hand hygiene guidelines. And as you probably recognize, those change quite a bit, or the World Health Organization hand hygiene guidelines. We are also working very strongly to prevent healthcare associated infections due to multi-drug resistance, reduce central line infections, associated bloodstream infections, reduce infections related to surgical site infections, and reduce anything associated with indwelling catheters associated with urinary tract infections. We also do mandatory COVID reporting on a local level, which is mostly to the county, to the state, and then also to the federal level, which is the Centers for Disease Control, or the NSHN. So next slide. So another area that we look at annually is what we call our risk assessment. So this kind of looks at what we think are the more serious areas that need to be focused on. And then from this definition, we then focus on particular areas that we think Washington Hospital needs to improve on or work on to try to improve our system for our staff and our patients. So the data is a little tiny thing that's hard to read, but what we're looking at is high risk areas and the risk associated by the scope of service. In other words, how many areas in there are particularly important. And we assign a number to them, 1 through 4. So 1 being probably not as serious, 4 being a more serious one. And so we use current resources, what we have available, try to figure out how we can best improve on this. And hang on a second, I just lost my screen. I have to keep going. So the methodology that we're using helps us identify our target areas. So for 2023, our target areas are obviously the COVID pandemic and what we can do to try to improve on that. And then also influenza, and we are currently, unfortunately, seeing respiratory syncytial virus, or RSV, surge. So it's interesting, usually influenza and RSV does not usually come into the circulating environment until probably sort of late January, February, but this year it's been much earlier. So our hospital has seen a number of patients that have been infected with respiratory syncytial virus, as well as increased numbers of flu. The other focus area that we wanted to work on is hand hygiene and personal protective compliance. So where staff is working with patients that need to have barrier protection, such as gowns, masks, shields, and gloves, we want to make sure that our staff are compliant. So we do kind of observations on the units and the floors to make sure that our staff are compliant. And we try to provide education when we think that they're probably not being as meticulous as our staffing suggests. We also do device-associated infections. Like I said, I will talk about this in just a minute. So catheter-associated bloodstream infections and catheter-associated urinary tract infections. We're also working very strongly to reduce any possible contamination for our instruments and scopes, and making sure that our cleaning practices are up to date. And the latest for that, we also are continuing to improve and standardize our infection prevention program components. And again, the area that I work with quite a lot is antimicrobial stewardship. So the carbapenem is an antibiotic that is a very strong antibiotic, which works against a number of bacteria that are typically very resistant. So we have seen this very rarely in our facility, but there are other facilities within Alameda County and the state of California that do have carbapenem resistant Enterobacteriaceae, which we call CRE. So we have designed a infection prevention program for those in particular to try to mitigate anything that we're seeing in there, and also to educate our staff, our nursing, and then patients also. If the patients are infected with it, so we want to make sure that they are aware of this, as well as families, so that they can be more comfortable in knowing that we're doing the best we can for them. Next slide. So key strategies for our calendar year of 2023. We started some of them actually in 2020. So this C. diff, which is Clostridia difficile infection. So we do a lot of abbreviations here. We have an algorithm, which is basically how we approach a patient who we think might have it or does have it. We have a new immunoassay that we've implemented through the lab, and also what we call our prevention bundle. In other words, how to look at a patient who might be infected, how do we protect them, also how do we protect our staff, and we do ongoing education to staff as well as our providers. Catheter-associated urinary tract infection, the nurses were very strong with this, helping us do a nurse Foley removal. So a Foley is a catheter that goes into the bladder that some patients need it for a short time, such as a urine collection, or sometimes patients after surgery or that have bladder problems need to have a Foley catheter long-term. So what we've done is try to focus both of the urologists, the surgeons, the nurses, and our infection control to try to figure out how we can best utilize the catheter so it's in there. It's like everything else, not too much, not too little, just right. So we developed a bundle, a compliance that's monitored electronically, and also we do monthly infection prevention rounds. And this is data is collected by Golnaz and presented routinely at medical staff groupings, our unit-based groups, as well as our other teams. So they're aware of what we're doing and why. So CLABSI is the catheter-associated bloodstream infections. So CHG is a cleaning. It's a lot like alcohol, but a little bit different. So and it comes in swabs and also wipes. So this was implemented by the strong support from the nursing for all patients who have a central line. So the other thing we did was a ClearGuard HD, which is a little protected pads, which is mostly used in the dialysis patients because they have very large catheters that obviously cannot be removed. Those are long-term in terms of dialysis. So we did a lot of this to prevent infections for those patients. And again, adherence to the bundle compliance is monitored regularly. We also started doing COVID response measures. So we're trying to immunize as much as possible our healthcare providers, our community members, patients who could get COVID vaccine resource availability. This, you may know, is through what we call the tent, which is in the parking lot of the 2500 building. So the hospital has been very proactive about providing immunizations, even the most recent immunizations, the bivalent, to almost anybody who needs it or wants to get it. So this has been a huge measure, I think, to improve our care for our patients and our community. We've also implemented enforcement of what we call transmission-based PPE policies. So a patient who has an easily acquired infection, such as methicillin-resistant staph, but also respiratory-borne, such as tuberculosis, So we're doing personal protection, which is the gowns, the gloves, the masks, the shields, and to make sure that we are adhering to our own policies. So our key strategies for improvement for 2023 is obviously reduce as much as possible any of our acquired surgical site infections, which is colonoscopy, which is COLO. And then the KP is the knee surgery. These are lingo, and also shoulder surgeries. We've identified those as particularly high risk because of with the knee and the shoulder, there's an implant of a foreign body, which is very susceptible to being infected. So we're doing ongoing observation of surgeries by the infection prevention team. We're also trying to reduce hospital-acquired device infections, as I mentioned. We're very strong with doing our COVID response efforts, which changes based on the status of the infection at the time that visitors and patients are coming in. We want to enhance transmission prevention. We're strongly pushing hand hygiene and personal protective equipment compliance. And I'll show you what we're doing in terms of our water management plan and an ongoing standardization of our infection prevention program. And a lot of this is done because we have the EPIC and can do surveillance. So this was, again, another very generous present from the board to give us this surveillance equipment, which puts us way ahead of a lot of other hospitals in terms of being able to track these infections to see where our, lack of a better word, hotspots are, where we can focus on most of our resources so we get the best results for our patients. Next slide. So these are active surveillance that we're doing for infections. These are mandated by CDC and California Department of Health. Again, it includes COVID, the influenza, respiratory syncytial virus, central line associated infections, ventilator associated infections, catheter associated urinary tract infections, vancomycin, which is a particular antibiotic resistant enterococci, MRSA, which is methicillin resistant infection, again, our C. diff, which I'll get to in a minute, the surgical site infections, the colostomy, the total hip and abdominal hysterectomy, among others, and then also monitoring for patients that might have infections with carbapenem-resistant organisms. So we have seen very little of this in our hospital, which is a very good thing, but we are very much on the awareness of this. If we see patients, we do education for the nurses for this. We have little signboards that go up when any patient is suspected to have this, so the nurses know exactly which PPE they need to use to prevent transmission. Next slide. So this talks a little bit about our construction programs. So we did the risk assessment tool to evaluate any new construction and to grade the risk for it. So for example, low risk would be ceiling tile replacement. Medium risk would be changing audiovisual cables. Medium high risk would be like sanding of the walls. And the highest risk would be what we're currently doing right now is renovation of the pharmacy and sterile processing. So you can see that's an extensive amount of intervention that's being done. So that's our highest risk. So we look at all the construction projects, determining which is low, medium, and high risk, and trying to make sure that the infection preventionist is following up with each one of those to make sure that we are staying in compliance. Next slide is talking about the water management that I said I'd bring up. So we do both temperature monitoring and also bacterial testing. The most onerous one is the Legionella, but we also look to see if there are other bacteria in the water. And so we do updated water management protocols to make sure that we don't have any other opportunistic infections. We collaborate with our quality, water quality vendor to track this. It's a testing system that they do on a regular basis to look at the water quality. And then that's reported to our infection control committee, as well as to other committees. Environmental services monitors that. So the water testing is done to assess the safety of the water, and the findings are reported. We also purchased a chlorine machine, which was installed as a mitigation to reduce what you call heterotrophic, which is mostly your yeast and your mold. So it's not so much the other bacteria like the staph and the Legionella, but the chlorine is mostly for the yeast and the mold. So the water management education is provided to all the engineering staff when they're being oriented or hired, and then on a every 3-year basis. So they're up to date on latest, greatest, best water management. Next slide is talking about environmental care. So environmental care means basically everything that we touch. So we do daily rounding to make sure that we are in compliance with our environmental care. We have environmental staff that are basically in-service huddles and one-on-one education where needed, because environmental services throughout our hospital. I mean, and we could not function without them. They use disinfectants on a regular basis, daily and terminal cleanings of all isolation rooms with bleach. They're involved in cleaning the public areas, the restrooms, cafeterias, lobbies, waiting rooms, everything top to bottom in our entire facility. We do what's called ATPS testing, which is one way to assure that the rooms are clean and ready for patients. So when the environmental services team goes through and cleans, they then do a short timeout before the room is turned around and made ready for patients. And then a second team from environmental services comes in and does swipe testing that's then done on a video that determines whether or not there's any what we call proteinaceous material. So it can't tell us there's exactly CRE or MRSA, but we can tell if there's any potential protein type material, which would also cover viruses, which we can't culture. So if there's, and it gives you a level. So if the level is quite low, then we feel like, okay, we've done a very good job with cleaning. If the level is again elevated, then basically the staff has noted that the room needs to be re-cleaned. It also identifies areas for improvement. So whether or not it's the handles on the doors or the handles in the toilet or the call light or the telephone or any of those areas are the areas that we monitor on a regular basis. And if we see anything that pops up as having a high level from ATPS testing, then the whole room gets re-cleaned, but especially identifying those areas that popped up as being needing more cleaning. Next slide. This is talking about antimicrobial stewardship program, which started in 2010. It's very interdisciplinary. So we have physicians, we have pharmacists, we have nursing, we have lab, we have environmental services, we have a huge team that works together. The pharmacists help us evaluate and streamline our antibiotic regimens, which we put into a protocol. So if physicians want to use antibiotics for a particular pneumonia or a skin and soft tissue infection or post-op infection, we have recommendations both for the medical unit and a somewhat separate one for intensive care unit, because we think those are much more likely to be resistant. We also look at our drug uses evaluation. So again, we want to use the right drug for the right patient at the right dose at the right time. And so we have targets that we look for to make sure we're meeting those goals. We have usage guidelines and we had education to all of our providers. I think stakeholders is a little odd, but whatever. So all of our providers, and this information even goes out to environmental services, to the pharmacy, to the nursing. We reach out to as many participants as we can. So again, C. diff, CDI infection screening algorithms, we updated that to try to prevent infection in our patients. Most of the times this is associated with patients that are being treated for an infection and getting antibiotics, which does sort of tip the body's balance so that instead of having normal bacteria, there's more of the C. diff infection. We also support hospital-acquired infections through physician engagement so that we're looking at that. And when we see that, this information goes back to the physicians so they can see where our target areas are. And then the absolute greatest person that I work with in antimicrobial stewardship is Lena Wong. She is our pharmacist consultant, and she is definitely dedicated. So she's a dedicated pharmacist who's extremely dedicated to antimicrobial stewardship, without which this program would be in serious distress. Next slide. So as you are aware, we're doing a triple endemic planning. So it used to be just influenza, but now we're dealing with COVID, influenza, and RSV. As I mentioned earlier, we're seeing influenza and RSV much higher and much earlier than we have in any previous years. So we're increasing our PPE level of protection. Again, the patient rooms have brochures on the outside, laminated flyers that tell our healthcare workers exactly what's needed to take care of those patients. With employee health, we updated our healthcare worker return to work policy. And we are also encouraging masking and screening for visitors. And this does change on a regular basis, depending on the level of the severity of the infections at any one time. So it may be a little bit confusing to visitors. They came in 1 month and they were asked to do one thing, and then they come in somewhat at a later time and say, well, things changed. And then so we try to say this is the most current recommendation to protect our visitors as well as protecting our staff and our patients. So a lot of times patients and staff and visitors want to know, well, what can I do? So vaccinate, get your flu shot, get your COVID shot, wear a mask, especially if it's in a crowded area. And if you're at high risk of complications from COVID, flu, or RSV, which would be sort of in our patients who have diabetes, patients who have asthma, emphysema, patients who are being treated for cancer, and also renal dialysis, and then also their family and visitors in the same category being much more susceptible. The other thing we'd like to say is if you're sick, please don't visit. Please stay home until you feel better. If it's absolutely mandatory that you go out to pick up, prescription or something like that, please, please, please wear a mask. The other thing you can do is to wash your hands. I don't think I can ever say this enough. Wash your hands, wash your hands, wash your hands. The hand sanitizers that we have in every section of the hospital are also very important. The other thing is encourage people to call their physicians or the healthcare providers. So if they have any concerns, to please call your healthcare provider and they can provide you with any additional information. The next slide is a little bit busy, which talks about our COVID confirmed cases. And this is taken from Alameda County. And so the very top left box is the Alameda County confirmed cases, which is about 370,000. And then Alameda County confirmed deaths, which is a little over 2,000. And then the box in the middle that I want to bring your attention to, you can kind of see the surges where the little lines tend to go up. So you can see where we had that very, very high surge in January of 2020. And then again, we had a less severe surge, but lasted a bit longer, was the surge that we had in July. And then we're starting to see again a small surge in January, February of probably into February of this year. So we're tracking that very closely, and we stay in touch with Alameda County. They have meetings every week updating providers from all the hospitals in Alameda County that participate on all of the data for any of the infections in Alameda County, whether it's tuberculosis, Legionella, and especially COVID, influenza, and RSV. So the next slide is talking about COVID prevention and control measures for 2023. So this is things that we want to implement and try to work on. So in terms of screening at admissions, we screen for symptoms of COVID prior to and upon arrival for all patients and visitors. Even our clinics, we're screening and asking them if they have any COVID symptoms. If they are, we're strongly encouraging them to please, either change your appointment to video appointment or telemed appointment, or maybe just reschedule. So we're trying to reduce any possible infections to our staff and to other visitors that might be in the offices or in the hospital. We do immediate isolation of symptomatic and high-risk patients. So if we're seeing somebody that looks like high risk, they're isolated immediately. We then go ahead to follow up with testing. And obviously, if testing does not show RSV, COVID, or influenza, then we treat them appropriately. We do universal masking for everyone, including our patients, when they're within 6 feet of a healthcare provider. We also do a safe visitor policy. So we want to make sure that our visitors feel safe when they come to visit, because we know how important it is for visitors to be with family when they need them and be there for support. So we strongly encourage the visitors to wash their hands or sanitize their hands, wearing masking, and also if they're sick, please stay home. It doesn't help the staff or patients or anyone if you're sick and going to share your infections. All admitted patients are tested for COVID. So that whether it's a minor procedure, such as, you know, having something minor done, to all the way up to our, you know, cardiac surgery type patients. So all patients admitted for surgeries and in the hospital in general get tested for COVID. So even our maternal patients get tested. The next slide goes into a little bit more on the COVID prevention and control measures. So safe practices, including this is for the transmission of COVID. Most of this is for staff. So we wear eye protection within 6 feet of a patient, whether it's a COVID patient or what we call PUI, which is persons under investigation. This was a little bit more common when we were seeing patients coming from nursing homes who had large numbers of COVID patients. So maybe the patient coming into the hospital did not necessarily have COVID, but since they were coming from a facility that had a large number of COVID, we would consider them under investigation. So we were very careful about using protective equipment for those patients until we got their testing back. We are still doing some asymptomatic testing. So again, patients who are coming from might have some cough or congestion, that we want to make sure that they are put into isolation until we get testing back. And then the other thing that we do isolation on is what we call aerosolized generating procedures. So this is similar to when you're using a nebulizer, like you somebody who has asthma or something. So a lot of our respiratory patients are treated with this aerosolized generating procedure. So all of those are considered, again, high risk. And so we're using protective equipment for all of when we're encountering any of those patients. We're also increasing the frequency of our surface decontamination, environmental cleaning throughout the entire hospital. We're maintaining consistent supply of personal protective equipment. Early on, this was a very difficult thing to do because the supplies were so very short. It was very, very difficult to get these, but we've done quite well. Again, our resource management teams have been very, very persistent about trying to find equipment and personal gowns, gloves, cleaning bags, everything that we need. We do communicate and plan, again, with local skilled nursing facilities and public health departments. We try to ensure adherence, again, to respiratory hygiene, cough etiquette, cover your hand, wash your hands. Again, physical social distancing, separation of at least 6 feet between patients while waiting if they're in the lobby or in the lab. And again, we follow national standards for healthcare worker safety. Next slide. I'll go through this very briefly because I've been talking a long time. So this is the C. diff that I talked to you about. We have seen increased rates throughout the hospital systems. We are at very low rate because I think we very aggressively manage this and are very proactive in terms of management of antibiotics, hand hygiene. We started a house-wide campaign in 2016. We looked at root cause analysis to see what we could figure out how to prevent this. Again, cleaning was a huge part of this, and environmental services have been a very big part of this. Infection prevention and also pharmacy. And we are currently doing, if a patient has diarrhea and we're suspecting they might have C. diff, we have a decision flow chart. So this helps us identify the patient, get the right test at the right time. And like I said, our C. diff ratio in 2020 was below the NSHN benchmark. So this is a kudos to our entire team, the physicians, the nurses, the cleaning staff, infection control, and all of our participants. I mean, it's a huge team effort. Next slide. So patients kind of want to know, well, what can I do? So again, hand sanitizing is very important. And again, with C. diff, we want to make sure they use soap and water. Part of that is because of the friction with the soap and water. We think that's much more effective than just the hand sanitizers. And these 3 bullet points go not only just to the patient, but also to their visitors. So if a patient has C. diff, we want them not to go into the common areas, which is pretty unusual now because of COVID restrictions, but want to make sure they stay in their hospital rooms and they don't go to like the gift shop or the front lobby. And again, we want to talk to the nurse if the visitors coming in to make sure they talk to the nurse first to make sure that they also get gowns, gloves, when they're going to go in and visit these patients. And also very important not to eat or drink inside the patient rooms because of potential for spreading. Next slide on C. diff. Again, is to wash their hands with soap and water, much more effective than the sanitizer. And also to use cloth towels that can be used cleaned, or disposable towels is even better. We use bleach to clean all of the surfaces, and we encourage patients when they go home to use bleach. That's much more effective than the standard disinfectants, and also use disposable gloves. They should change and wash linens with hot water when they're doing laundry. And we also want to make sure that patients, if they get a prescription for treating C. diff, to make sure that they take it exactly as prescribed and not to stop early, because patients sometimes say, well, I'm feeling much better. I don't feel like I really need it. But we try to strongly encourage them to make sure that they take these antibiotics right time, right dose for the right reason. We also encourage patients and providers, if they suspect that they're infected, to please notify their healthcare providers so that we can do testing and also track anybody that might have infection that they've come in contact with. Okay, the second bug that I'm going to talk about is very briefly is TB. Next slide, sorry. This has gotten a lot better control with Alameda County, but I think because we're unfortunately isolating. So at Washington Hospital, we do 100% of employees, staff, physicians are required to have annual TB testing. So we take this very seriously. We collaborate with Alameda County to monitor and survey the incidents. We screen patients that we think are suspect. The nurses can on their own, it used to be a physician order on their own, they can put a patient in airborne isolation if they suspect that. So they don't need to wait for a physician to call back and confirm that. This is a continuous negative pressure room. So basically the air is being pulled back out, and they have a exhaust that's on the window. So there's little chance that any of the contaminated air from within the room will get into the hallways or other areas. The diagnosis is made after the physician sees the patient. We do confirmation. The county is notified by infection prevention, and we do collaboration to make sure that the patients, when they go home, are treated appropriately. They make sure they get the proper medications, because some of these are fairly costly. And the patients are educated on care and why they really need to maintain their medications at the time of discharge, as well as encouraging patients to maintain isolation, because they potentially can spread this infection to any of their family or visitors, or if they're going out in public. And also if they do need to go out of the house, like if they're going to go to a testing or a lab or something, that they make sure that they wear masks. Next slide. So in terms of staff education, staff is our backbone. We could not make it without them being educated and being supportive, and they are very supportive of all of these programs. So 100% of the staff is required to do infection prevention education model annually. Education is provided to new hires, nurses, graduate students, as well as environmental services, pharmacy, dietary. We do ongoing education with huddles and one-on-one basis. We have educational materials that we present. We have a website that they can go and look if they're unclear which isolation does this patient need. We have it on our intranet, and it just pops right up. We have annually a patient safety blitz, which is actually kind of fun because people get to sort of chat. I don't think we've done it too recently, but we get to chat and share ideas. We have an employee health and safety fair. We have COVID that basically is screened and educated for all staff. So SABA is our educational trainings modules. So this is done pretty much annually, where things that are of concern, so that we're educating them on the most current information. So SABA is a individual slide set that they can look at and monitor, and we included COVID with all of that, especially like the donning and doffing is on our intranet, how to properly put on and take off PPE. Our infection prevention is on that, and all of the COVID information that's up to date is on that as well. Next slide. I'm getting to the end. This is the last slide. So future direction. So we want to maintain compliance with health-associated infections in line with Medicare and Medicaid services and Center for Disease Control. We want to continue doing ongoing comprehensive multidisciplinary infection prevention rounds. We do that on the floors and talk to the nurses, and it's a very good give and take dialogue, because when I've been there and doing some of this, I learned what the on the ground team, what their challenges are and how can we support them, because without supporting them, they're the ones who take care of our patients and basically take care of us as well. So the data is reported quarterly to Clinical Evaluation Committee, to the Nursing Oversight Committee, Multidisciplinary Infection Prevention Committee. I also present to individual departments of the physicians, medical, surgery, and family medicine, and also to the General Medical Staff Committee, which is what Dr. Hyder was talking about we did last night. We're working very hard to prevent healthcare associated infections. As much as I like infections as an ID physician, I would like to see a lot less of them, because it does impact the care of our patients, and it does impact the care that we are able to provide for patients. So I think the less infections, the better off we're going to be. We want to sustain improvement, including our catheter-associated urinary tract infections and catheter-related associated bloodstream infections. Both of these, with the work that Gulnaz and her team has done to educate and work with the nursing staff to prevent these infections, has been enormous. So we are not quite to under the guidelines, but we have significantly improved in both these areas. So if you want to see data points, I can submit that to you later. You can look at that. We also are doing further preparation for outbreaks, for emergencies and surge management. So surge management in terms of COVID, emergencies in terms of monkeypox. It's now called Mpox. So we worked very carefully with the county to provide Mpox vaccines for any of our patients who want it. And we're also looking at doing prevention for Ebola outbreaks. So for those of you that remember that way back, what we did for Ebola, we're starting to see potential for that. So we're working on getting in the background. We've not seen patients yet, but we want to be prepared. So we're looking at in the background, if we were to get notified we had a potential patient, what do we do? How do we do that? Same thing that we did for educating staff for Mpox. We see a patient that's suspect, where that's serious suspect or mild suspect, we want to make sure that we take care of those patients very appropriately for their benefit as well as for the benefit of our staff, so that they're not exposed to something. I think that's the end of my slides, and I'll take questions.
Dr. Martin, thank you very much. Comprehensive,
You're welcome.
wonderful report. It's wonderful.
So I have to thank Mary, Gulnaz, and Lena. They're a huge support, and without them, would not be able to do this program.
The fun thing is that we've made tremendous progress in all areas there. I remember not long ago when the C. diff was quite a problem. And it's nice to have that almost non-existent.
I mean, our numbers have dropped significantly. We have been so impressed with what the pharmacy, the nurses, environmental services has been able to do.
Yeah. Any other questions from board members?
Yeah, Diane, this Bill, can you comment on why you think we might be seeing the higher rates of RSV and influenza earlier on in the state this year?
You know, that was commented on by CDC, and they've been looking at it, and I don't think that they know either. I've not seen a really good explanation for that. I mean, I don't know if it's we've opened up to a little more travel and maybe not using masks as much, but usually we don't see influenza or RSV until way after Christmas. And this stuff basically was starting to be very prominent in late October, early November. So I've not seen a good explanation. That's a really good question. I don't think I've seen anything. I know they're trying to see if they can sort it out, but they pointed out, even in a meeting I was in December, that's a huge infection control meeting, they were quite perplexed.
Yeah, thank you. It's had a big clinical impact. Yeah.
Yes.
Darn bugs seem to outsmart us at every turn.
Yes, well, I think we're managing pretty good. I think we've got the upper hand on most of them for right now.
And then a new one comes along, right?
Exactly.
Anyway, again, thank you. Thank you very much, Dr.
Okay,
Moore.
my pleasure. Always an honor to come talk to you guys. I appreciate all the services that you do as well.
Appreciate your help. You have a good evening.
Thank you. So I'm going to sign off. Thank you. If somebody has questions, you can either email or call at any time.
Thank you again. Our next agenda item will be our finance report. And for that, we turn that over to Chris Henry, our Vice President and Chief Financial Officer.
Okay, thank you, Dr. Stewart. Tonight we'll be looking at the operating and financial results for Washington Hospital for the month of November. And we'll jump right in. Inpatient average daily census for the month came in 16.6% higher than budget at 163.7. Our combined average daily census, which includes our outpatient observation patients, came in 12.9 higher than budget at 171.7. Admissions were 22.8% higher than budget at 969, and our patient days for the month were 11.2% higher than budget at 4,910. Outpatient observation equivalent days for November were 109 lower than budget at 241. And our average length of stay came in lower by 0.57 or 10.2% at 5.02. Moving into utilization. Case mix index for the month, which is the indicator for the severity of the cases that we saw during the month, came in lower than budget at 1.466 for the month. So the cases were not as severe as we had budgeted for. Deliveries came in 19.8% higher than budget at 145. I think that's the largest number we've seen in quite some time for deliveries. Surgical cases came in 17 higher than budget at 385. However, cath lab cases volume, they're still continuing to struggle at 181 against a budget of 216. Outpatient visits for the month were 349 or 3.9% lower than budget at 8,560. However, the emergency room was very, very busy, seeing 5,126 patients, or excuse me, patient encounters for the month against a budget of 4,583. So again, OR continues to just really be busy. Moving quickly into the detail of surgical and cath lab cases. In the OR, joint replacement cases kind of led the charge, 21 over budget. Neurosurgical cases and cardiac cases combined down below budget by 6 cases. And then our other surgical cases pretty close to budget at 173. We had budgeted 171. In the cath lab, same story that we've been hearing over the last several months. Peripheral vascular, non-vascular interventional radiology, and neurointerventional radiology cases combined were 53 cases below the budget for the month. The shining star here was our cardiac cases, which were 18 above the budget at 112. Moving into productivity, productive FTEs for the month were 7.4% below budget at 1,364.7. We had 244.5 non-productive FTEs in the month. That included 15.6 FTEs that were taking advantage of the COVID supplemental leave payments. So we ended the month with total FTEs that were 32.6 higher than the budget at 1,609.2. However, our full-time equivalents per adjusted occupied bed, again, that's our productivity indicator, came in 4.6% lower than budget at 5.96. Moving into the financials, total patient revenue for the month came in just under $9.8 million higher than budget at $198,916,000. Our deductions as a percent, contractual and other deductions as a percentage of revenue came in very close to budget at 76.79, and that really carried over all the different categories. Our contractual allowances very close to budget as a percentage of gross revenue at 74.89% versus a budget of 74.96, actually a little bit better than budget there. And our provision for bad debt and charity came in, there are some rounding differences, but basically right on budget at 1.9%. So we ended the month with net operating revenue almost 2.4 million higher than budget at $46,670,000. Operating expenses for the month came in $2,254,000 higher than budget. Big driver here for the month was our benefits. That was almost $1.5 million higher than budget. There is a story here. This is related to, goes back to last January when we changed our third-party administrator for our healthcare plan. During that switch, we issued new insurance cards to all of our employees, and those cards had a new number associated with them. What appears that had happened is early on in this, a number of our employees' providers continued to bill Blue Shield under their old ID numbers. And those subsequently were, of course, not honored by Blue Shield. So it took some time for the providers to kind of unwind this and make sure they were, and our employees too. I think our employees had a lot of work to do getting their providers to bill under the new ID to HealthComp. So it's just taken time for all those claims to work through, and really they're hitting now. So about 1.5 million of that is related to that issue. They're old claims that got hung up because they were billed incorrectly in the beginning by the providers. Also over budget for the month was our supplies. It was over budget about $718,000. Saw that in the area of prosthesis with our higher joint cases. Our drug costs were up, drug and blood bank, and that was more related to inpatient census than anything. So we did end up the month with an operating bottom line pretty close to budget, about $123,000 higher than budget at $2,579,000. Non-operating income for the month came in a little bit over $1.6 million higher than budget at $1,595,000. As you can see there, mostly driven by an unrealized gain on our investments of just under 1.5 million. We haven't seen one of those in a while. It's nice we'll take it when we can get it. So in this environment, it's nice to see that. So we end the month of November with net income on the bottom line, almost $1.8 million higher than budget at $4,174,000. We had budgeted $2,420,000. Taking a quick look at our Financial Accounting Standards Board, this is a I'll wait for the page. Okay, so this is a representation of how the financial markets might adjust our Governmental Accounting Standards Board presentation that we just looked at to make them more comparable to FASB financial statements. So the first thing they would do is they'd reclassify our revenue bond interest expense out of the non-operating category up into operating expenses. And we would end up with operating expenses of $44,652,000 about 5.2% higher than the budget. And operating income from a FASB perspective of just a little bit over 2 million against a budget of 1,833,000. Next thing they would do is throw out our GO bond interest expense and the tax revenue that supports the debt service on those bonds, as well as that unrealized gain on our investments. They don't recognize any of those. We'd end up with non-operating income of $280,000 against a budget of $214,000, and net income of just under 2.3 million against a budget of $2,047,000 from a FASB perspective. Moving into our earnings before interest, taxes, depreciation, and amortization, and this gives us an idea of the kind of income that the operating and non-operating activities of the hospital are generating for certain expenses. First thing we do is we look at our operating expenses before depreciation, which, as we've discussed before, is a non-cash item. And we end up with EBITDA for the month of just under 6.2 million against a budget of just over 6 million, just under 6.1 million. So about $123,000 variance there. Next thing we do is we look at our non-operating income before our interest expense, and we end up with about $3,298,000 there. So in total, operating and non-operating activities at Washington Hospital generated about $9.5 million of income to support the debt service, capital spending, and program development that's going on here at the hospital. So are there any questions on November?
Yeah, Chris, this is Bill. Where did that unrealized gain on the investment come from? I'm a little surprised at that in our current interest rate environment.
Yeah, it's just been a volatile market, Dr. Nicholson. I don't know exactly what drove it, but we did see the value of our investments go up.
Oh, that's better than down.
Mr. Wallace might have a better outlook on that.
It's all temporary. It probably reverse the next month. It's just wild swings in interest rates.
Okay. Yeah. Okay.
It's looking good this month. I mean, so far in January, there's a really big bond rally. So whatever may have reversed in December, this gain probably will get the gain back in January. So
yeah, it's really hard to predict, isn't it?
Yeah.
Yep.
Okay, we can move on to our operations report with Kimberly.
All right, I am presenting December of 2022 this evening, and it was another busy month for the hospital healthcare system. Gross revenue of $207 million for December was above budget by $13.5 million or 7%, and was above December of 2021 by $13.5 million or 7%. Inpatient gross revenue of $128.4 million was above budget by $14.1 million and $19.6 million above December of 2021. We saw basically room and board and inpatient ancillary services revenue were both above budget. Our outpatient gross revenue of $78.6 million was below budget by $580 and $6.1 million below December of 2021. And again, we've had some challenges continue with outpatient cath lab, and also you'll see that our outpatient observation revenue was also below budget. In December, there were 116 COVID-19 discharges, representing 12% of total discharges. And this was an increase of 58 cases from the prior month and 81 more than December of 2021, where we only had, in December, 35 discharges. Also in December, there were 53 flu and 26 RSV discharges, representing about 8.1% of total discharges. Moving into the key census, the average length of stay of 5.36 was below the budget of 5.61 by 0.25 or 4.5%. and this was also lower than December of 2021 of 5.4. There were 11 discharges with lengths of stay greater than 30 days, ranging from 31 through 66 days. Excluding these outliers, the length of stay was 4.91. Still in-house at the end of the month, we had 8 patients with lengths of stay over 30 days, and they ranged from 33 to 50. Our outpatient observation days at 238 were below the budget of 349 by 111 days, or 31.8%, and 99 days, or 29.4% below December of 2021. We have a lot of work that we've been doing in terms of looking at our operations and our efficiency. We do have the portal of entry program and the consolidation of our observation patients on one nursing unit, which are helping to contribute to the lower observation days for our patients. Our inpatient average daily census of 178.3 was above the budget of 147.2 by 31.1 or 21.1%, and above December of 21 average daily census of 150.1. The combined average daily census of 186 was above the budget of 158.4 by 17.4%, and 15.5% above the December of 2021 average daily census. Moving on to our admissions trend, our admissions of 981 were above the budget of 813 by 168, or 20.7%. December 2022 admissions were 14.6%, or 125 above December of 2021. Again, we saw the increase in COVID cases and also increase in inpatient surgeries that all contributed to the higher admissions. Patient days trends, patient days of 5,528 were above budget by 966, or 21.2%, and were 874 days, or 18.8% above December of 2021. So again, really showing a busy month. Looking at our surgical trend, our total surgeries in December of 362 were below budget by 1, or 0.3%, and surgeries were 35, or 8.8% below December of 2021. Inpatient surgeries at 152 were 17, or 12.6% above the budget, and 15, or 10.9% above December of 2021. It was our outpatient surgeries at 210 that were 18, or 7.9% below budget, and 19.2% below December of 2021. Surgical activity, in terms of that broken down, our joint replacement surgical cases were above budget by 11, or 7.6%, but were 25, or 13.9% below December of 2021. As you know, the Peninsula Surgery Center has been open. The Peninsula Surgery Center saw 18 cases in the month of December. We are still working through some of the contracts, but also physicians had time off just given the holidays in December. Our neurosurgical cases were above budget by 3, or 10.3%, and were 10, or 45.5% above December of 2021. So busy neurosurgery month. Also, our cardiac surgeries were above budget by 1, or 7.7%, and were 4 above December of 2021. We'll note in December we had 6 TAVR cases, which is the highest number we've had since the program implemented in January of 2021. All other surgical cases combined were below budget by 16, or 9%, and 13% below December of 2021. And a lot of that was driven by physicians taking time off. Moving on to our cath lab. Cath lab cases for December at 147 were 61, or 29.3% below the budget of 208, and 27.6% below December of 2021. Inpatient cases at 85 were 20.6% below the budget of 107, and 10.5% below December of 2021. And our outpatient cases were at 62, were 38.6% below the budget of 101, and 42.6% below December of 2021. We continue to really, we're working on recruiting and rebuilding the IR program, but as we know, physician recruitment is challenging, but we continue to work to bring in additional IR physicians to help them reestablish the program. Looking at our cath lab activity, our cardiac cases were consistent with budget and 10.4% above December of 2021. However, non-vascular interventional radiology, peripheral vascular cases, and neuro IR cases were lower than budget by 61 cases combined and 64 lower than December of 2021. Moving on to our deliveries. Deliveries for December of 124 were above budget by 3 or 2.5% and 9.5% below December of 2021. Let's see. Moving on to a non-ER outpatient trend, our non-emergency outpatient visits of 8,199 were below budget by 638 or 7.2%, but above December of 2021 by 12.3%. It was primarily driven by lower lab visits, and unfortunately that's also tied to our cath lab visits because we had less pre-procedure testing given that we had the fewer cath lab visits. We also had some challenges in some of the other areas given the holidays and a number of days that others were out. Moving on to emergency room visits, we did have a very busy emergency room in December. We saw 5,517 visits, which were above budget by 802 or 17%, and 714.5% above the prior year. We believe, looking back, this is the highest visit count that we've seen in a month over the last 5 years. So again, very busy. There were 228 patients with influenza, 46 patients with RSV, representing about 5% of the visits. We saw about 273 COVID positive patients, or about 4.9% of visits versus 355 COVID positive patients in December of 2021. So less COVID, but also seeing influenza and RSV too. So very busy emergency room. Looking at our total gross revenue, it really aligns with the trends of our volumes. You'll see our surgical cases were below budget by 1 case at 0.3%, and revenue was above budget by 746,000 or 2.1%, really driven by the higher cardiac and neurosurgeries that were above budget. Room and board revenue was above budget by 6 million or 16.2%. As I mentioned, patient days were higher than budget by 21.2%. We did see lower ICU days than budget, so that brought down in terms of some of our revenue. Our deliveries were above budget by 3 or 2.5%, but revenue was below budget by 346,000, and that was due to 5 fewer C-sections than budgeted. Emergency room visits were above budget by 17%, and revenue was above budget by 1.6 million or 12.6%. We did see a higher percentage of lower acuity visits than expected. Our cath lab cases were below budget by 29.3%, and revenue was 4.6 or 35.2% lower than budget. And ancillary services revenue was above the budget by 10.2 million or 11%, and this was again primarily driven by the really busy inpatient activity. So moving on to our preliminary payer mix. Unfortunately, we had a very busy month, but our payer mix at this point is not looking as favorable as in other years or other months. Government-sponsored patient revenue made up 73.8% of total gross revenue. This was higher than the budget of 71.5% and higher than the prior year's percentage of 70.1%. Our HMO was 3% of gross revenue, which was higher than the budget of 2.6% and higher than the prior year's percentage of 2.8% of gross revenue. PPO was 21.8% of gross revenue, which was lower than budget of 24.3% and lower than the prior year's percentage of 25.2%. And lastly, private pay was 1.4% of gross revenue, which was lower than the budget of 1.6% and lower than the prior percentage of 1.9% of gross revenue. Looking at our productivity indicators, our productive FTEs were above budget by 125 or 9.2% at 1,485.3. Non-productive FTEs were above budget by 34.9 or 16.1% at 182.2 FTEs. We're below budget. Sorry if I said above budget. Below budget. And we had COVID-19 supplemental sick leave were 10.6 FTEs, and this was lower than the November 15.6 FTEs. So total FTEs of 1,667.5 were above budget by 90.1 or 5.7%. And as you could tell by our busy activity, had a lot of productive FTEs and weren't able to give probably as much time off in terms of non-productive time. Looking at our productivity indicators, our productive FTEs per adjusted occupied bed of 5.17 was lower than the budget of 5.46 by 5.3%, but higher than the prior year of 5.04 by 2.6%. Our total FTEs per adjusted occupied bed of 5.8 were lower than the budget of 6.33 by 8.4% and slightly lower than the prior year of 5.81 by 0.2%. All right, moving on to our outpatient statistics. As you can see, Whitman clinic visits were below budget in December by 6.4%, and they were 12.4% visits below December of 2021. Really, the main driver of this, we had PCP visits that were below budget by 3.8%, but the main driver really was our specialist visits that were below budget by 17.6%. And a lot of this was a combination of two factors. We had a number of physicians taking time off higher than last year, but also we have vacancies in vascular, thoracic, ENT, were some of the areas that we do have vacancies in right now in terms of physicians. Moving on to our DevCo outpatient visits, they were 2,366. They were below budget by 72 or 3% for December and 11.1% above December of 2021. As you can see, our Washington Outpatient Rehab Center volume was above budget by 11 visits. Rock treatments were above budget by 7. And as you know, we had some challenges with the facility, and even then we came in above budget. Our surgery center visits were below budget by 59. Peninsula Surgery Center visits were also below budget by 67. And then Loney College Students Health Center were above budget by 36. Moving on to the key financial statistics, our days cash on hand for December ended at 155 days, an increase of 1 day from the prior month and 8 days lower than the same period in the prior year. I do want to say we did see the increase in days cash is due really, we had a really high total collections of $52 million for the month, which really is an increase in 5 days, but that was offset by higher operating expenses of $2 million and also our quarterly pension and OPEB plan contributions of $2.8 million. So we did well with higher total collections, but that was offset by the expenses and the contributions. Do want to say our days in accounts receivable continue to see that going down. They were at 59.1. This is lower than the prior month by 2.5 days and 8.7 days below December of 2021. So continue to see good progress there. And there were 386,000 in charity care adjustments in December of 2022. Just lastly, I do want to just give the homeless patient activity for the time between July and December of 2022. 534 patients resulted in 934 patient encounters. During this time period, 159 patients had multiple encounters with the hospital. The estimated unreimbursed cost of homeless care, decreased compared to prior year by 3.1%, but the cost per encounter has increased from $3,179 this fiscal year to date versus $2,937 for last fiscal year to date. The cost of homeless care includes food, clothing, pharmaceuticals, transportation, and housing, in addition to hospital staff labor and avoidable inpatient days. So any questions? That is the month of December. As I said, we had a busy month that also had some challenges in different areas.
Thank you very much, Kimberly. No questions. We can move on to announcements.
All right, I'm going to start with the Employee of the Month, Michelle Thomas. She's a Financial Assistance Coordinator. When she had the opportunity to join Washington Hospital in the Patient Accounting Department, Michelle knew her background as a medical assistant and phlebotomist would help her bring a patient-facing approach to the role. She started as a confidential clerk in 2016, and Michelle understood that for many patients, she was the face of the hospital. She immediately embraced the patient-first ethic, treating each patient as she would want a member of her own family treated. After less than 2 years, Michelle accepted the role of Financial Assistance Coordinator, working closely with a financial counselor. Michelle enjoys her role of helping to see if patients qualify for financial assistance. Michelle knows that people are turning to her and her coworkers after medical emergencies and is glad that they can offer assistance during these trying times. She contributes to her department in many ways. In addition to her patient accounts, her coworkers will note that from a jam printer to understanding how to order supplies, Michelle will always step up to help with whatever is needed. Her manager describes Michelle as a multitasker with a sincere patient-first ethic. She goes above and beyond to either help a coworker or work with one of our patients on an account. Raised in Castro Valley, Michelle comes from a large extended family, and now she and her husband are raising 2 young children. When not at the hospital, they enjoy visiting Bay Area parks for walks and bike rides, weather permitting, of course. And our patient financial services department and our patients are fortunate to have Michelle Thomas working with them. Congratulations to the January Employee of the Month. All right, just moving on to just giving an overview of our promotion and community outreach events that has happened over the last month. We really just had one, given the holidays, we had one past health promotion event that Maria Nunez, Clinical Manager of Stroke Program, presented stroke awareness to the Vintage Courts retirement community, and 10 people attended. In terms of moving forward to the month of January, we do have some promotion events and outreach events coming up. We do have Wahi Khan, our licensed marriage and family therapist, is presenting self-care and self-compassion keys to well-being on the 12th, which is tomorrow. We also have Dr. Russell Nord, orthopedic surgeon, who's going to be talking about shoulder pain causes and treatments on January 19th. Also on January 19th, Tammy Tyson, our Director of Oncology, along with Christine Mickelson, they will be talking about breast cancer prevention, early detection, and treatment at Acacia Creek. And lastly, on the 28th, Washington will be participating in the Lunar New Year celebration that is hosted by the City of Fremont. And you can see the 2 of those events will be on Facebook Live and YouTube. We have a couple more events happening in January. We have Christy Caracappa, our Health Information Coordinator, that is going to be talking more about Medicare and what you need to know at Cozier Retirement Community. Dr. Saw on January 25th will be talking about hip replacements, the anterior approach, and he's a orthopedic surgeon, and that will be a hybrid, both in person and on Facebook Live and YouTube. Then in February 2nd, J.B. Goodyear, our spiritual care coordinator, will be talking about grief, loss, and personal care at Acacia Creek. And on February 7th, Dr. Thomas Collins Pallett will be talking about managing diabetes on Facebook Live. So we have a number of community events coming up. As you can see, our vaccination clinic continues to be busy. We've vaccinated to date about 98,173. We've given that many doses to date. Also, in terms of our foundation report, every year the foundation participates in Giving Tuesday, which occurs the Tuesday after Thanksgiving. This year, in November of 2022, generous donors contributed over $8,500 to support our maternal and child health programs at the hospital. We will be having on February 7th a free charitable giving and estate planning seminar, and that will take place at 5 p.m. in the Anderson Auditoriums in Washington West. And lastly, I want to make sure everybody puts it on their schedule. May 4th, 2023, at the club at Castlewood in Pleasanton will be our 36th annual golf tournament. And that is my report. Dr. Stewart.
Thank you very much, Kimberly. We will now go into a closed session. However, before doing so, I want to let the public know that they have a right to know what reportable action, if any, was taken by the board in the closed session. Normally, the board would make that announcement following the closed session. As we do not know how long the closed session will last, we do not want members of the public waiting indefinitely on the phone for the board's report. Therefore, we ask that you contact the district clerk tomorrow. She will be happy to respond to any inquiries about the reportable board actions. Our minutes will continue to reflect any reportable actions taken. Thank you. The board will now adjourn to a closed session.